Thank you very much. I really appreciate the kind introduction. It illustrates the danger of social media when people learn about you and see photos of you doing things other than medicine. So I'd like to thank the meeting organizers for bringing me home. And when I say home, I mean literally home. I was born about 5 or 6 blocks north of here in the former Flower Fifth Avenue Hospital. So it's wonderful to be back. I try to come back to New York as much as I possibly can, even though I've been in Boston now for 25 years, and it is true that I am one of the team physicians for the Red Sox, which brings forth all sorts of conflict at family dinners at holidays. So this is a really interesting area with a lot of evolution recently, the use of angiotensin receptor neprilysin inhibitors in heart failure, and I'm really grateful to have been invited to speak on the topic. My disclosures are here. Most relevant is that I've done clinical trials sponsored by Novartis looking at the use of sacubitril/valsartan. So why are we talking about this topic? Well, and we're sort of jumping from this is sort of cardiology grab bag this morning, one area to another. So we're in the heart failure space now. So why are we discussing novel therapies in heart failure? Well, over the years, it's become well understood that the pathophysiology of heart failure is driven by upregulation of deleterious pathways such as the sympathetic nervous system and the renin-angiotensin-aldosterone system. And because of that fact, we've been able to harness that understanding to develop therapies or use therapies that block, for example, the sympathetic nervous system using beta blockers. The renin-angiotensin-aldosterone system we block using RAS inhibitors. But notably, the strategy for managing heart failure, generally speaking, until recently, has not been to raise positive pathways, such as, for example, the natriuretic peptide system, to counter-regulate or counterbalance the deleterious physiology in heart failure. Stated another way, if we block all the bad stuff, why not try to raise the expression of proteins that are favorable in heart failure? So the natriuretic peptides, for example, lead to vasodilatation, they lower blood pressure, they reduce sympathetic tone. Essentially, they counter-regulate the activation of the renin-angiotensin-aldosterone system. And there have been some efforts over the years, and this is by no means a novel idea. The therapies to enhance the natriuretic peptides, in particular neprilysin inhibitors, have been studied for 20 years in the heart failure space, but it's only recently that therapies have been successfully brought to patients in order to improve outcomes in heart failure. So when we think about the various pathways, the natriuretic peptides, ANP, atrial natriuretic peptide, BNP, B-type natriuretic peptide, and CNP, these all bind to their cognate receptors, leading to an increase via cyclic GMP in all the favorable things, whereas angiotensin II, for example, binds to its receptor, causing the upregulation of the deleterious pathways. So hypothetically, if we can somehow enhance the good while reducing the bad, that would be desirable. So neprilysin is an endogenous metalloproteinase found pretty much everywhere in the body, but particularly in the heart and in the kidneys, that degrades numerous vasoactive peptides. It's not just the favorable ones. So seen here is just a list of various vasoactive peptides that neprilysin degrades, and you'll appreciate that although at the top of the heap we see 2 of the 3 natriuretic peptides, ANP and CNP, we also see some vasoconstrictive substances like angiotensin I and II. So if you inhibit neprilysin without blocking some of the vasoconstrictive things, you get a net null effect because you raise vasodilatory peptides, but you also raise vasoconstrictive peptides. So neprilysin inhibition alone is not going to be enough to favorably affect the path of heart failure. The other thing I'll draw your attention to is the fact that in this list of substances, we have the relative affinity for neprilysin. You'll notice that ANP and CNP are all the way at the top of the heap, whereas BNP is all the way at the bottom of the heap. And we'll get to that in just a little bit when we start talking about the understanding of the mechanism of action of the drugs containing neprilysin inhibitors. So this comes forth now to about 10 or 15 years ago when sacubitril valsartan was developed. This is a combination angiotensin receptor neprilysin inhibitor, or ARNI drug. The drug contains a somewhat odd dose of valsartan because it's actually a novel preparation of valsartan, which, when administered in the doses contained within sacubitril valsartan, delivers the same biological effect, the same bioavailability of good old-fashioned valsartan, formerly known as Diovan. Right? So this combination of sacubitril valsartan includes a neprilysin inhibitor, sacubitril, which gets converted from its prodrug form into an active form that inhibits the breakdown of numerous peptides, including the natriuretic peptides, and valsartan, which of course we know binds to the angiotensin II receptor. Now you might say, well, why not use an ACE inhibitor, right? Why use an angiotensin II receptor blocker? Well, it turns out that prior studies combining a neprilysin inhibitor with an ACE inhibitor, specifically a drug called omapatrilat, very potently lowered blood pressure and in fact acted quite nicely as a vasodilator. The problem is when you combine an angiotensin converting enzyme inhibitor with a neprilysin inhibitor, it increases the risk for the most dreaded complication of neprilysin inhibition, which is angioedema. So because of that fact, drugs containing ACE inhibitors together with neprilysin inhibitors were no longer pursued, hence the need to use a drug that doesn't cause this problem as much, which is valsartan, which directly binds the angiotensin II receptor. Okay, and we'll get back to the whole safety piece in a little bit. So this idea of blocking the bad and raising the good is basically what underlies the whole concept of use of sacubitril valsartan. You are probably aware of the results of the PARADIGM-HF trial. This is a study of more than 8,000 patients randomized either to enalapril 10 milligrams twice daily versus sacubitril valsartan in patients with heart failure and a reduced ejection fraction. These are patients that largely had ejection fractions below 40%. The study started off with an EF cutoff of 35, and then they raised it to 40. So it's 40% or lower. And in the PARADIGM-HF trial, in fact, if you look at the DSMB cuts of the data, the PARADIGM-HF study was actually positive at 30 days after the study initiated. These curves diverged immediately. This is heart failure, hospitalization, and cardiovascular death. And by 1 year, there was a 15% relative risk reduction, and then 20% out to about 4 years. The study was terminated early because of overwhelming efficacy, with a p-value of 1 × 10⁻⁹. So really remarkably strong result. The primary endpoint of cardiovascular death and heart failure hospitalization, which is sort of the benchmark in heart failure trials these days, was one important point. But if you look at any of the endpoints in the trial, they were all reduced by about 20%. So all-cause mortality, heart failure hospitalization, as well as cardiovascular death were all reduced substantially. Notably, the mechanism of death was sort of interesting in that not only did, as we might expect from a drug that affects the renin-angiotensin-aldosterone system, enhancing natriuretic peptides, that worsening heart failure would be reduced, makes sense, but sudden death was also quite significantly impacted as well. So, you know, anyone that takes care of heart failure patients is probably nodding knowingly right now as to why that may be. But I want you to remember the fact that sudden death was reduced because we're starting to develop clarity as to why that is. So when we think about the comparative effects of angiotensin receptor neprilysin inhibitors compared to other inhibitors of the renin-angiotensin system, ACE inhibitors and ARBs, we see in general, you know, both of these drugs reduce risk. We know this from numerous trials from the late 1990s and early 2000s. Above and beyond that, if you do an imputed placebo type analysis, the value of sacubitril valsartan against placebo would be a near 40% reduction in mortality, and the benchmark of composite of heart failure hospitalization and death, but even above and beyond ACE inhibitors and ARBs, there's a benefit. And I think that there's a general consensus that regardless of the philosophical issues that people have about the cost of the drug, there's clear evidence that the use of sacubitril valsartan compared to other conventional RAS inhibitors is associated with better outcomes. Because of that fact, the ACC/HA HFSA guidelines have now embedded sacubitril valsartan as a class 1 recommendation right up there next to ACE inhibitors and ARBs. The idea of putting them all together here is to say to people, hey, you've got to be on a renin-angiotensin blockade agent. But after 30 days of stability, and the reason why they chose 30 days is because in Paradigm there was a run-in period before patients were put onto sacubitril valsartan where they first had to tolerate an ACE inhibitor. After 30 days, people should be switched from an ACE and an ARB over to an ARNI. So where are we now in 2019? Well, there's been a big flurry of activity in the last 6 months in terms of understanding that has evolved regarding angiotensin receptor and neprilysin inhibitors. And this includes a better understanding of how these drugs work. Paradigm HF was actually done without a phase 2 trial. So they went from phase 1 to the pivotal phase 3 Paradigm HF trial. And phase 2 trials are generally done to understand mechanism of action, right? And so we had this resoundingly positive study with early termination, and people were sort of scratching their heads saying, well, why in the heck did the drug reduce sudden death, for example? Why is it so much better than an ACE inhibitor? So that's one. So we have some new understandings here about mechanism of action. There is a recent study published showing the role of sacubitril valsartan in patients with acute heart failure. Remember, Paradigm was chronic heart failure. So there's an acute heart failure with reduced EF trial, which I'll show you. And then lastly, unless you haven't been watching the New England Journal recently, there was a paper looking at the role of sacubitril valsartan in HFpEF, heart failure with preserved ejection fraction. So let's start first in the evolution of understanding of mechanism of action. Just how in the world does sacubitril valsartan do what it does? Well, the first point is that, I'll remind you that as a neprilysin inhibitor, it enhances the effects of the natriuretic peptides, in particular the natriuretic peptides that are a target of neprilysin. So ANP, BNP, and CNP, the endogenous bioactive natriuretic peptides. In contrast, the propeptides for each of those three, so let's talk about BNP. Amino terminal pro-BNP, or NT-proBNP, is a biologically inert propeptide. It is not degraded by neprilysin. Therefore, when a patient is placed on sacubitril valsartan, their BNP values tend to rise because neprilysin degrades BNP. So if you inhibit it, the BNP values go up, whereas the NT-proBNP values tend to fall, right? So the simple take-home from this slide is if you're drawing a natriuretic peptide on a patient taking sacubitril valsartan, NT-proBNP is much more reliable about giving you the general status of the patient, whereas BNP tends to go up variably. Around 20% is what's been reported in patients treated with sacubitril valsartan. So the question is, does every patient have the same rise? More fundamentally, does every BNP assay show the same value of same change, given the fact that each BNP assay binds to different places in the BNP ring? So we published a paper in JACC last year, or this year actually, looking at patients where we intensively sampled blood and also measured a whole bunch of biomarkers, looking at the effects of sacubitril valsartan on various BNP assays. Seen here is just the varying effect on multiple BNP methods, just showing that you can't assume that from one test to the next and from one patient to the next, that their BNP is going to be as reliable when you're measuring it to try to monitor patients. Same thing goes for NT-proBNP actually. Although they all fall, each different vendor's natriuretic peptide assay responds somewhat differently. That's interesting, sort of more germane to those people who are interested in lab medicine, but more fundamentally what we found in these patients was that the small rise in BNP just doesn't seem to explain the large rise of urinary cyclic GMP that these patients develop. So what might explain this? Well, we measured ANP in these patients as well, ANP is the prototypical target for neprilysin. It only has a half-life of 8 minutes because it's so vulnerable to neprilysin. And what we found in our patients in this study was that ANP went through the roof in every single patient, with an average doubling, and in some patients a tripling or quadrupling. So it is now a prime hypothesis that the thing driving much of the benefits of sacubitril valsartan is probably a wholesale rise in ANP concentrations. And we're in the process now of measuring ANP in a much larger cohort. That cohort is a study called the PROVE-HF study. So the idea behind PROVE-HF was to look at the associations between changes in natriuretic peptides and cardiac structure and function in patients treated with sacubitril valsartan. I'll remind you again that there was no phase 2 trial before Paradigm. So the effects of sacubitril valsartan on ejection fraction, left ventricular volumes, diastolic function, left atrial volume remain somewhat ambiguous. That's on the one hand. On the other hand, we knew that sacubitril valsartan reduces natriuretic peptides, which are tightly associated with all of those cardiac structure and functional correlates. So what we did was we enrolled 800 patients with symptomatic heart failure with reduced ejection fraction eligible for treatment with sacubitril valsartan. Following enrollment, patients had their ACE inhibitor and ARB stopped. Remember, you must stop the ACE inhibitor at least 36 hours before starting a patient on this drug to reduce the risk of angioedema. After initiation of sacubitril valsartan, we drew blood at multiple time points across a 1-year period. We imaged them with an echocardiogram at baseline, 6 and 12 months. These echoes were interpreted in a randomized fashion to ensure the data were sound. What we saw was a rapid and significant reduction in NT-proBNP, not unexpected. We see this clinically all the time, which is within the first week or two of treatment, there's a robust reduction in NT-proBNP in these patients, which was sustained out to a year of follow-up therapy. We found that the reductions in NT-proBNP were significantly associated with the subsequent changes in ejection fraction, end diastolic volumes, and systolic volume, atrial volume, as well as diastology. How much change did we see in these measures? Well, from baseline 6 to 12 months, there was a rise from a baseline of 28% ejection fraction by 5.2% at 6 months, and 9.4% increase, absolute increase in ejection fraction by a year. It's important when you're talking to your patients about the changes you see in their echoes when they initiate and titrate on therapies. A 1-year average increase in ejection fraction of 9% is really enormous when you think about the other therapies we give in heart failure. Indeed, if you look, the top 25% of subjects had a rise in their EF of 13% or more. Again, this is not a relative rise, this is an absolute increase. Not surprisingly, with that increase in ejection fraction, we see significant reductions in left ventricular volumes. Similarly, we saw reductions in left atrial volume and improvements in diastology. In a post hoc analysis, we found that left ventricular mass index also fell by 16 grams per meter squared. So really all just showing a really potent reverse remodeling impact from sacubitril valsartan on the ventricles of these patients with pre-existing chronic HFrEF. Now, again, why does sacubitril valsartan reduce sudden death? It improves ejection fraction, right? And when we think about the prime predictor of sudden death in patients with HFrEF, often it's how low their ejection fraction may be. So this brings it full circle to better understand how the drug works. We also, in this trial, enrolled patients that had not previously been studied in other trials like Paradigm, including those that were naive to ACE inhibitors or ARBs, those with new onset heart failure, those with low natriuretic peptides, as well as those that couldn't get to the top dose of sacubitril valsartan. And in each category, the reverse cardiac remodeling in these patients was comparable. So that's understanding the mechanism of benefit and action. What about its role in acute heart failure? And that's the Pioneer heart failure study. So Pioneer was a study enrolling patients, about 800 patients again, admitted to the hospital with acute reduced EF heart failure. In these patients, they had to be stable. I want you to remember these bullet points. They had to have a solid blood pressure 6 hours before starting on sacubitril valsartan. They could not have had intensification of intravenous diuretics. They could not have been on intravenous inotropes and no IV vasodilators. These are patients who have been diuresed, they're warm and wet, and now they're being diuresed down, and now you're on a stable diuretic dose. That's the time to switch them over. The proportional change in NT-proBNP was the primary endpoint, but they also looked at clinical endpoints as well. So here's the serious composite endpoint. So the natriuretic peptides were dramatically reduced, as you can imagine, compared to enalapril. Here's the serious composite endpoint, which is looking at death, heart failure, rehospitalization, VAD, or transplant. Significant reduction. I'll draw your attention to the fact this was driven entirely by a non-significant but nonetheless eye-opening reduction in mortality and a reduction in heart failure hospitalization, which as a standalone metric that we all care about these days was quite substantially reduced by the initiation of sacubitril valsartan versus enalapril. So really telling data suggesting, and we in fact at the MGH Heart Center start sacubitril valsartan in hospitalized patients. But some practical tips if you do this. Number one, you've got to educate everyone involved in the process. This includes nursing, pharmacy, and other people that see these patients, because there are some important things you need to think about. First and foremost, from a safety perspective, you need to get the ACE inhibitor out to reduce the risk for angioedema. Also, we find, practically speaking, that just like we do in chronic heart failure, we reduce the loop diuretic empirically to avoid the risk for hypotension. So in hospitalized patients, it's probably not a good idea to initiate sacubitril valsartan in someone getting high-dose IV loop diuretic until you're ready to dose reduce the diuretic. Start the sacubitril valsartan at a time when the patient is still a little bit volume overloaded to mitigate the risk of very upregulated renin-angiotensin-aldosterone system in these patients, and you'll find that the blood pressure lowering effects of the drug are really mitigated quite nicely. Lastly, and most important, you heard Dr. Rosenson mention the cost of the drug. It's actually a little less than a PCSK9 and covered quite well, but it's something that we often have to deal with a prior authorization. And if you've got a patient in the hospital, it is a big mistake to discharge them without making sure the paperwork is addressed before discharge, so they don't go to the pharmacy and then get denied, and they're standing there after a heart failure discharge without any agent to take to reduce their renin-angiotensin-aldosterone system. So we routinely get a 30-day supply for our patients from the pharmacy at the hospital, and then make sure their paperwork for their outpatient pharmacy has been arranged. Lastly, evolving clarity about the role of sacubitril valsartan in HFpEF. I'll remind you that heart failure with preserved ejection fraction comprises about half of the patients we now see with chronic and acute heart failure. Patients with HFpEF have a lower mortality rate generally than patients with reduced EF, but they get hospitalized just as frequently. They are recidivistic. They are in and out of the hospital all the time and a real pain to take care of in that sense. Lastly, and quite bothersome to all of us in the heart failure space, is we have nothing that has been proven to reduce mortality for our patients with heart failure with preserved ejection fraction. So there was great hope that sacubitril valsartan might unlock that, conundrum. So the Paragon HF trial, another rather large trial by heart failure standards, nearly 5,000 patients with symptomatic HFpEF. Notably, the EF cutoff for Paragon was an EF of 45%. Remember that. That is not often what we think of when we think of HFpEF, right? We think the preserved EF is 50 or even 55 or greater. So they included in Paragon patients in the so-called mid-range, which you'll see is relevant. These are people with symptomatic HFpEF requiring diuretics. They needed to have structural heart disease, and they needed to have elevations in natriuretic peptides. So pretty solid population of patients with heart failure and preserved ejection fraction. In this trial, patients were randomized after a run-in period with valsartan to sacubitril valsartan, another run-in, and then they were randomized to either sacubitril valsartan at top dose or valsartan itself at top dose. Now again, notice the differences in the doses of valsartan between the two arms. Here, because of the novel preparation, 103 twice a day of the valsartan in sacubitril valsartan is the same thing as 160 twice a day of Diovan, or good old-fashioned generic valsartan. People have asked, well, why not randomize to placebo? The problem here is that patients with HFpEF typically are hypertensive. They typically have diabetes more often than not. And so it really would have been not only extraordinarily complex, but probably unethical to randomize against placebo, even though valsartan and other ARBs have not been shown to definitively reduce risk in patients with HFpEF. There was a trend towards benefit in the CHARM study suggesting that maybe there was some benefit. So when I show you the results of the trial in a second, you might think, well, if they hadn't gone up against high-dose valsartan, maybe the trial would have been positive. And indeed, when you look at the total hospitalizations and CV death in the trial, valsartan was associated with around 1,009 events, and sacubitril valsartan was associated with 894 events. Now, before I show you the p-value, if you were a Bayesian person, if you're someone who looks at these curves and says, well, geez, if they followed the patients just a little longer or had a few more events, this study would have been positive. But frequentists would say, well, I don't care about that. The p-value is 0.059. It's a negative trial. Heartbreaking, right? We're so close to the potential of a study that would be conventionally called positive. This study was conventionally positive at the last DSMB cut. And between the last meeting of the Data Safety Monitoring Board and the closure of the trial, there were 7 events that tilted it over to a negative study. So for all of the discussions about whether the study was positive or negative, I would argue that it's sort of lost. It's lost on everyone when we look at this result. They were so close to having the first conventionally positive study for HFpEF, compared to all the other studies that have been done. This result was driven entirely by reductions in heart failure hospitalization. Now, here is where I think the more appropriate philosophical discussion would be. For an expensive therapy, is a reduction in heart failure hospitalization alone sufficient to justify use of the drug? Let's say those 7 events hadn't occurred and the trial was called positive. And that's a debate that we're not having because the study is sort of viewed as negative, but still, I think it's important to sort of take that on. So depending on how you look at the various analyses done in the trial, they all look just as the main analysis did, right on the fence, right on the margin of what we would call a positive study. What is of note and of interest is that when you look at secondary endpoints, all by definition exploratory because the main trial was technically negative, there was improvement in quality of life with substantial differences in the number of patients with dramatic improvements in quality of life scores. And in addition, kidney function was better preserved in those patients randomized to sacubitril valsartan versus valsartan. If you look at pre-specified subgroups, I'm not putting this up here for you to go picking through each group, but there are 2 groups that jumped off the page with respect to the statistical interaction, and that was in women. The drug was associated with a strikingly positive result, whereas as well as in those patients with somewhat lower ejection fractions. And you can say, well, wait a minute, these are people with preserved EF. True, but remember that patients with an EF of 45 or greater were enrolled in this trial. And so when you split the patients by their median EF of 57%, those patients at or below the median EF, essentially below 60, there was a substantial reduction in cardiovascular events, whereas those patients at or above the median of 57% had no benefit at all. When you take a step back and look at them more closely, here's men versus women, and here's EF, 60 and greater or less than, right? So really kind of interesting and starts raising some hypotheses as to just why the trial went down the way it did. Here are the ejection fraction data now in a little more granular detail. And so here's the overall EF. You can see crosses crosses 1, so the neutral trial, bless you. If we look at low EF, below 50, patients between 50 and 57, pretty comparable. It's when you get up to 57 or greater that the drug seems to start lagging. Sort of curious, right? So why might that be? Well, this is just a hypothetical construct I put together. I took a 5 a.m. train this morning. I've been up since 3:30. So if it's confusing, try to understand. I'm a little delirious. If you think about benefit, larger benefit seen in people with lower ejection fractions, these are people with more RAS activation, right? Renin-angiotensin system activation, with a more predictable phenotype. Whereas those patients with higher ejection fractions have generally less RAS activation and importantly have much more heterogeneity in terms of their phenotype. Specifically, in the HFpEF population, who are the male patients with EFs greater than 57%? They are the patients with amyloid, hypertrophic cardiomyopathy, severe valvular disease, ischemic heart disease. A pill is not going to help these people, right? So these are, unless you think about treating amyloid, these are people with diagnoses that are probably less medically treatment responsive, right? So my philosophical view of the results of Paragon is that it's not that women benefit, it's that older men with preserved EFs, with higher preserved EFs do not. Right? So it's an important and interesting observation, but still leaves us wanting for a therapy that we could give to our patients. So in conclusion, ladies and gentlemen, in 2019, we have this evolved understanding about mechanism of action of a drug that's now a class 1 on the guidelines and widely available for treating patients with chronic heart failure with reduced EF. There's an expanded and I think evolving role of the drug in acute heart failure with reduced ejection fraction as well. As I said, we've implemented it quite widely now at Mass General. Lastly, there's some disappointing clarity on the role of sacubitril valsartan in chronic HFpEF. I think the story's not quite done. You can expect that there's going to be interest in moving forwards with some kind of regulatory approval for the drug, either for improving quality of life or for treating people with EFs less than 57%, because that's the number in the trial. We'll see. Even though the trial was neutral, there's been recent studies that the FDA has approved therapies off of that were neutral overall, but they approved for subgroups in particular. So we'll see what happens with that. And with that, I will conclude that across a wide range of heart failure presentations, treatments with sacubitril valsartan, treatment with sacubitril valsartan is associated with improved clinical outcomes. A better understanding is now established how the drug works, and it seems pretty clear it's likely an enhancement of endogenous natriuretic peptides, specifically ANP. The success of sacubitril valsartan and other therapies to reduce risk in HFpEF, I think, really needs to be more focused on the varying phenotypes in HFpEF rather than just saying if you've got heart failure and an EF greater than 45%, you should get the drug. And as I said, I think it's likely we will be treating people with ejection fractions all the way up to about 55 to 60% with this therapy eventually, but that remains to be entirely proven. So with that, I will stop. Thank you very much for the attention.